Hello, I am Dr. Joseph Jamal. I am a fellowship-trained robotic urologist. I am the director of robotic urological services at nyu-winthrop Hospital, and I am a partner in Integrated Medical Professionals, a large urology group. Prostate cancer, unfortunately, is a very common diagnosis affecting up to 1 in 7 men across the country. If you're meeting with me here today, most likely your surgery and your cancer is going to be for localized disease. So what that means is, if we are meeting to discuss surgical strategies regarding the prostate cancer, by all indicators, all of the cancer seems to be localized within the prostate and therefore is potentially curable. So although this may not apply in every single situation, most of the patients that I meet with are going to be okay. And I know that's a hard thing to think about, and we can certainly talk about the nomograms, the predictive calculators, in terms of how the prostate cancer is going to be treated, what the best strategies are. Right now, we're going to go through a little bit of an overview, what I typically talk about for patients with regards to the surgery itself. In the actual meeting with each other, I'm going to discuss the specific patient factors, the specific cancer factors that will allow us to determine what the best strategy is for you. So what I tell everybody in the office is that I'm here to help as a guide for you. Although I'm a surgeon by training, a lot of what we end up discussing in the in-person meeting is really what the best fit is for somebody. There's not one best answer. If there was, you wouldn't have to go to multiple meetings with different doctors and different specialties to figure out what the best strategy is. Instead, really it's what's best for you. And that is related to a number of issues, including your health, your age, the cancer itself, previous conditions, previous surgeries, previous radiation, and then also managing the expectations of each of these factors. A lot of it also has to do with the kind of cancer and the aggressiveness of the cancer that you have. So when we discuss the management and what the best strategy is, surgery may play a big role, there may be no role for it. But either way, it is important for all the patients to see both a surgeon and a radiation oncologist in determining the best strategy moving forward. Now, that being said, we're going to discuss surgery as one of the options. We're going to do a general overview, and then in the in-person meeting, when we meet here, we'll end up discussing the actual specific patient factors. So here we are back at the surgical stage. When we discuss surgery for prostate cancer, really the discussion is about something called robotic surgery. Now, robotic surgery is not new. It's been out for about 15 years. I've been performing it for over 10 years myself. And when we discuss the management of prostate cancer, and we discuss the surgery for prostate cancer, surgery is done with a robotic-assisted approach 95% of the time around the country. What that means is, instead of doing a large incision inside the abdomen, we end up doing a surgery which revolves around laparoscopic instruments. And so what we do is, we can put 5 ports in the belly and fill up the patient with CO2, carbon dioxide gas. Instead, the alternative would be an open incision in order to get our hands inside and to remove the prostate. The problem with the prostate is that it's a very small organ, deep inside the body, and it's underneath the pubic bone, it's fused to the rectum, to the bladder, to the muscles. It becomes a very difficult organ to maneuver around and to remove safely and effectively. By allowing us to do these things laparoscopically and robotically, we can place a telescope into the patient, zoom in on the patient, and magnify the area. We can also place very small, delicate instruments through all of the 5 ports that we have here. So, general configuration is going to be 5 little incisions here around the abdomen, and that's how we initiate the procedure. So the procedure is done in the operating room. Under anesthesia, general anesthesia, the patient's completely asleep, will not feel anything at all. When the patient's asleep, we place 5 of these ports in after filling the abdomen with CO2 gas. After all 5 of these ports are placed, we then attach the robot to the outside. That allows us control to manipulate the instruments inside the body. After I've done all of that myself, I then sit down at a console here, and this is the surgeon robotic console. The robotic console allows us to do very precise surgery. So taking it from here, We see the patient asleep on the bed. Anesthesia has already done everything that they needed to do to make sure the patient is safe and secure. We've then placed our ports inside the patient, as described before. Once these ports are placed, I can take a seat at the robotic console, and inside the console I can see inside the body in 3D. By seeing in 3 dimensions, we have the depth perception to see how close and how far things are from each other. This allows the surgeon much more precision in terms of how we're able to grasp and handle the tissues and the depth perception that allows us to do that more precisely. Additionally, my hands and feet are able to control a variety of instruments inside the patient. So through these ports, I can place a camera, a scissor, a clamp, sutures, all the different tools that we need. This allows us to, again, to control a multitude of instruments simultaneously without the aid of assistant to be significantly important during the surgery. So as we can see here, the surgeon can sit at the console. He's right next to the patient. There is a bedside assistant who stands right next to the patient to help with suction, really. Inside the console, we see in 3D, and our hands are controlling small instruments inside the body. The hands and the fingers are controlling joysticks, and the joysticks are allowing us to move the very small, precise instruments inside the body. As you can see, the tips of the instruments move with what's called wristed maneuvers in 7 degrees of motion to mimic exactly the way our hands move. Now these instruments are about this big at the tip and long and slender. Here we can see a zoomed in version of the patient. Penis is here, prostate is here, bladder is here. These yellow structures here come from the spine, and these are the nerves that go into the base of the penis, which help us control erectile function after the surgery. Here, the prostate is seen visualized in this orange color. The bladder is in this brown color. We start by placing the telescope above. We can take a look around. We remove the fat on top of the prostate. We then separate where the bladder and the prostate are, trying to preserve as much of the bladder muscle fibers. And then we release the nerve bundles off the side of the prostate, and that allows for better both sexual function and urinary control after the surgery. We then separate the urethra and the prostate here from the middle, and then we begin to lift and roll the prostate away from all of the structures, including the rectum from below, the remaining muscles attached here, and the nerve bundles on the sides. As we remove the prostate, we worry about a couple of things. First and foremost is the cancer. So depending on where the cancer is, we're going to be a little bit more careful when we do the operation. When we do surgery, we attempt to do a nerve-sparing operation, and we can grade the nerve sparing from 100% nerve sparing down to 80%, 50%, or less, depending on the aggressiveness of the cancer and the patient desires. We basically tend to cheat in towards the prostate in order to save more of the nerves, and we cheat away from the prostate and go wider in patients who have more aggressive disease. This allows us a little bit of a balance and also allows us to tailor the surgery individually to create a custom-made approach for each patient. Based on where the cancer is, let's say this patient has cancer along the left side over here. When we're doing the operation, using both the preoperative biopsy as well as the MRI information that we have, we are able to stay as close or as far away from the side of the prostate as we need to be. So here on this side, for example, if the patient has left-sided cancer, we may stay a little bit wider, maybe save 100% of the nerves on the right side and 90% or 80% of the nerves on the left side. During the operation, as we do roll the prostate away from the nerves, we're going to lift the prostate up, and if the cancer was here, well, I'm going to take biopsies here and here on the prostate. This allows us to send the biopsies down to the pathologist who is in the hospital, and within 10 minutes, the pathologist can call me on the phone and say, Dr. Jamal, your biopsy at the base and the mid are clean, or at the apex, or at the bladder neck, any of the places that we're concerned about. So anywhere where the patient has preoperative cancer, where the MRI is of concern, or if I see something that I don't like, I send intraoperative biopsies in order to create, again, a custom-tailored surgery for each patient. Now, if the pathologist tells me there's cancer at any one of these sites, I get that information in 10 minutes during the surgery, and I'm able to remove more of the tissue if needed. Again, very nuanced approach, but we're able to basically remove more and more tissue until we can achieve a negative margin. Unfortunately, that comes at the risk of compromising some of the nerve function or some of the muscle function. So therefore, it is all in balance. And we try to do this custom-made approach for each and every case. Now, in terms of the cancer, we remove the prostate completely. It gets placed into a bag and sealed. We take lymph nodes on both sides, depending on the risk of the cancer. And then we begin with our reconstruction. The reconstruction involves placing a catheter into the penis, reconstructing the bladder, where we bring the bladder down to meet the urethra with a Rocco stitch, and then we do an anastomosis, where we basically place a watertight running suture around the entire periphery of the connection between the bladder and the urethra. That catheter stays in for approximately a week. So in total, the surgery usually takes about 2 hours of time to perform. Patients are in the hospital one night. I expect you to walk the same day as the surgery and then begin walking the morning after the procedure. We start with liquids initially after the surgery and then progress the diet as indicated. But in general, 95% of the patients have left the hospital by post-op day number 1. And most of the patients have the Foley catheter in, draining urine from the penis for 1 week. After 1 week, you return to the office and we remove the catheter over here. Now, 6 weeks after the surgery, 4 to 6 weeks after the surgery, we will end up getting a PSA test. Your PSA should be below 0.1. That indicates an undetectable level of PSA, the prostate-specific protein associated with prostate cancer and prostate tissue in general. So I alluded earlier that there are 3 main things that I worry about. And the reality is I want all these 3 things to be equal. And I want what the patient wants. I want the cancer to be cured, we want urinary control to return, and we want sexual function to recover. Those 3 things, in that order, are the most important things for both the patient and myself. And I struggle and strive to achieve that on every single case. That is not possible. Depends on a multitude of factors, including the aggressiveness of the cancer, the patient comorbidities, size of the prostate, preoperative function. So with cancer control, like I said, we achieve negative margins to the best of our ability, and we check a PSA postoperatively. With regard to urinary control, we have to do a number of things in order to maximize our outcomes. Now, I'm going to move over to this demonstration model here, and we're going to go over a couple of things. So as we've said, there are 3 main things that we have to consider when we discuss prostate cancer surgery. Number 1 is the control of the cancer. Secondary is urinary control. And third is sexual function. So I like to use this model over here to discuss the return of urinary control. It's important to understand that the return of urinary function after removal of the prostate is going to be sometimes a time-consuming process. And it's important to understand that, and the way that I try to make this analogous to is, imagine if you've had a knee replacement, a hip replacement, shoulder surgery, any of these other things that are essentially going to create a reconstructed area, and that the recovery process is contingent on the inflammation resolving, the body recovering, the nerves and the muscles interacting in a new way. So when we talk about the return of urinary control, it can be a very variable process, sometimes a few weeks, sometimes months. When we discuss the return of urinary control, it's going to be a somewhat frustrating process. Now, 90% or more of our patients will recover excellent urinary control and will either not need any pads at all or will wear one small liner in their underwear a day when they're fully recovered. That's about 90% or more based on my patient data. When we discuss the timeline, though, again, it's very patient specific. So the return to function is based on the recovery of this muscle right here. This is called the external urethral sphincter. And this external sphincter is essentially the valve that opens and closes when you urinate. It's important to understand that this is a muscle just like any other, and that it can take time for it to bulk up and thicken and recover after a big surgery. So I actually have patients start before the surgery. I have you start doing Kegel exercises before the surgery 20 to 30 times a day. that'll build up and bulk up the muscle, and it'll create a muscle memory to make it easier for the patient to do the exercises after the surgery. A Kegel exercise is an exercise where you essentially contract your rectum and squeeze the entire pelvic floor. When you do so, the penis, which is normally flaccid like this, will pull in, and you'll feel the penis pull in. If you look at it, it will pull in. You may feel some tingling at the tip of the penis as everything gets contracted internally. I want the patient to hold that contraction for about 10 seconds and then relax for 10 seconds. Now, it's easy to say that. Another way, another analogy would be if we imagine that the urologist is trying to place a finger inside the rectum, or if we're trying to place a probe inside, and the patient, you just don't want to let us in this time, understandably. So I want you to squeeze the rectum, hold tight, and try to prevent somebody from getting their finger in. That's another way of thinking about how to do a Kegel exercise. And the last way that I explain to patients is imagine that you're standing at the urinal, and in the middle of your stream, you want to stop your urine. You can stop the urine midstream by squeezing the rectum, tightening it, holding for 10 seconds, and then relax and release it. So this is a way of practicing the Kegel exercise before the surgery, making the muscle bigger and thicker and stronger, and also building up the muscle memory. These are all important factors so that after the surgery, your recovery is a little bit smoother. The way I want you to try to remember to do 30 exercises per day is that every time you hit a red light in your car, you squeeze, you hold your butt for 10 seconds and you relax. Every time you sit down, again, you squeeze for 10 seconds and you relax. Every time you pass the urine, whether you're standing or sitting, I want you to try to stop the urine, hold for 10 seconds, and then open and release again. This will get you 30 times a day where you're contracting, you're strengthening the muscle, and you're building up the new muscle memory that'll be really important for everything after the surgery. So again, it might take a few weeks, it may take up to 6 months of recovery to get to the point where over time you go from wearing 2, 3, 4, 5 diapers per day in the beginning, and that's the reality. I want you to be prepared. I want you to be prepared with diapers. After the surgery, when you come in, a week later, we take the Foley catheter out, and when you leave this office, I want you to come to the office with a diaper or pads to put into the underwear, so that when you leave, you don't have any surprises, or at least you're prepared for the surprises. The diapers will wane, everything will improve. 90% or more of patients will not require diapers eventually, will not require pads, will wear nothing at all, or will wear a small liner. So it's important not to exercise for the first month to avoid putting too much pressure on the bladder, which would make the urine leak out. Another trick is to do a Kegel exercise while you're doing certain movements. For example, when you get out of the car or out of the bed, you're putting a lot of pressure on the bladder. So if you do a Kegel and you squeeze your the external sphincter down and prevent the outside pressure of the bladder, you're going to counteract the leakage essentially. And the stronger that Kegel muscle is, the better you're able to counteract the external pressure. The thing that I want my patients to understand is that when you go home and you're leaking, just remember it is normal and everybody gets better. Stay positive. Use the diapers. Don't be embarrassed by it. It will all get better. The third thing that I wanted to discuss was the recovery of sexual function. Now, sexual function is very important. It's not always the most important thing, but certainly for different patients, it's of variable importance, and we need to discuss it because of the side effects that can occur. This is one of the ones that's the most difficult to anticipate and the most difficult to control. In general, the most predictive factor for the erections after the surgery is going to be how good are the erections before the surgery. Preoperative function is the single best predictor of postoperative function, and that makes sense. Some 55-year-old patients will have excellent erections, and other 55-year-olds won't have very good erections at all, even with the use of medications like Viagra. It's important to remember that nothing that the surgeon does is going to make the erections any better. Anything that we do messing around with the nerves is going to negatively impact the erections. Therefore, the best that I can hope for as a surgeon is to get you to where you were before the surgery. And that's sometimes achievable. In about 50 to 80% of patients after surgery, patients will have sufficient erections for penetration and intercourse. It's a big, wide range, and it's certainly not 90 or 100%. 50 to 80% is a realistic expectation. It's lower when patients have worse preoperative function, and it's higher when patients have better preoperative function. Again, the function of the erections before is the best predictor. The other predictor is the ability to do a nerve-sparing operation. And that nerve-sparing operation is contingent on the amount of cancer and the severity of the cancer and the location of the cancer. Therefore, somebody with a low-risk, low-cancer disease, we're able to basically cheat towards the prostate. And so when I describe the removal of the prostate, we're essentially taking the prostate and rolling it away from the nerves. And this is important because the prostate and the nerves are fused together. By releasing the nerves from the prostate, we are putting the patient at risk of sometimes leaving cancer at the edge of the margin. So what we do is, the more aggressive the cancer is, the wider and the wider we go in terms of the nerve-sparing operation. Somebody with less aggressive cancer and less volume, we can achieve 100% nerve sparing on each side. Somebody with more aggressive cancer, we're going to cheat out. We're going to save 90 or 80 or 70% of the nerves. And again, the two sides are going to be a little bit different. So we may save 100% of the nerves on one side and 50% of the nerves on the other side. It's important, but it's not the only factor. So when we discuss the nerve-sparing approach, we do perform a nerve-sparing approach on every patient, but the degree of nerve sparing is either 100% or less depending on the patient factors. The expectation after surgery, once the catheter is out and the patient is comfortable, the homework assignment is going to be to take a sildenafil or a Viagra or a Cialis every day as a low-dose maintenance therapy. What that does is it helps promote blood flow and oxygenation to the penis and to the erectile and nerve tissue in the area. The other thing that I expect patients to do after surgery is to try to achieve an orgasm twice a week. Now, that can be either alone or together with your partner. Either one is acceptable. A lot of times I'll recommend to spend some time alone because this way you won't have the frustration and the expectation of the partner. This is all, again, a very personal preference. So try to achieve the homework assignment that I'm asking for, which again is try to achieve an orgasm twice a week. Now that's important. Orgasm, when you have an orgasm after prostate cancer surgery, is a rhythmic contraction of the muscle, but no fluid comes out of the penis. Remember that the prostate made fluid for ejaculation. So you can have an orgasm, but there will be no ejaculated fluid. It's a cleaner process, if nothing else. That's one of the main differences. The other difference is that an orgasm can be achieved even with a weak erection or no erection. So regardless of wherever the erection process is in healing, if you have a 20% erection or a 50% or 100%, you can still have an orgasm even with a weak erection or a soft erection. So again, the homework assignment is going to be twice a week, take a full dose of Viagra an hour before, which is 100 milligrams of sildenafil, an hour before trying to have an orgasm. Try to have the orgasm, and essentially what that does is it pushes the body to achieve the best erectile function you can at that point. It will be better at 2 months than it would be at 1 month, for example. As long as you're getting to orgasm, the erection is improving, right? That's the important part. The timing is very different. For some people, it takes a few weeks. Other people, it takes months. Up to 18 months, the erections will continue to improve. Now, again, very important to discuss the patient desires here, because some patients want to get in the game sooner rather than later. If somebody is okay with waiting, then we wait. We take our time. We let the erections kind of return slowly and more naturally. If a patient just gets frustrated, if he needs to be intimate with his partner, if it just makes him feel more confident, there are other things that we can do. In addition to the medications that are used orally, we can use a ring at the base of the penis, which helps trap some of the blood inside the penis to prevent the leakage of blood flow back in. And this ring can be a very useful adjunct or additive to the use of medications. The last option is going to be to place an injection in the side of the penis. Now that might sound like it's painful, it's really very minimally so. And if a patient desires an erection, that's the easiest way to guarantee that they will have an erection and be able to have penetration and orgasm and everything else. It's a personal issue. I don't tell everybody that they have to start injections right away. In fact, it's an option, and if it's something that the patient wants to pursue, we can certainly help them in pursuing that. We can order the medications, treat the patient, teach them how to do it, and therefore they don't have to wait 6 months or 12 months or 18 months. Again, it's a very patient-specific scenario. The recovery is very variable, depending on a lot of factors, some of them in our control and some of them outside of our control. The best thing we can do is to partner with the patient to help them to achieve the best outcome that we can, and the way that we do that is by discussing with our patients as much as possible. I hope you understand that the prostate cancer surgery is a very difficult process for the patient, and that essentially we are your partner in trying to help you to achieve the best outcome possible. In summary, prostate cancer can be a very difficult process to go through. We are here to help you, to educate you, and to help you make the best decision for you. There are pros and cons to every single decision that we make. Pros and cons to surgery and radiation and surveillance. Our goal is to provide you information and to help you become comfortable with the best decision for you. I look forward to meeting with you in the office, and certainly look forward to answering any other questions you may have.